Welcome to our Pharma Topics channel. Welcome to the new video on anti-gout drugs. Before entering into this, let us see the pathophysiology of gout. It is a disorder of urine metabolism characterized by increased uric acid levels, that is hyperuricemia. It may be due to two reasons. One is increased production of uric acid. The patients may take increased purine-rich foods, or there may be reduced excretion of uric acid. Hyperuricemia may be of two types. One is primary hyperuricemia, where the cause is unknown or there are enzyme deficiencies, or secondary hyperuricemia, which occurs in diseases such as leukemia, psoriasis. Some drugs can also lead to secondary hyperuricemia, such as thiazide diuretics, loop diuretics, levodopa, cytotoxic drugs, and pyrazinamide. And excessive alcohol intake also leads to secondary hyperuricemia. In gout, there is a deposition of monosodium urate crystals in and around the joints, leading to recurrent, acute or chronic gouty arthritis. In patients with severe hyperuricemia, urate crystals are deposited in the larger joints, and that may cause renal damage. Let us see the classification of anti-gout drugs. There are two categories. One, the drugs used for acute gout, and one is the drugs used for chronic gout. The drugs used in acute gout include NSAIDs, colchicine, and corticosteroids. Chronic gout, the treatment includes uricosuric drugs such as Probenecid, sulfenpyrazone, uric acid synthesis inhibitors such as Allopurinol and Febuxostat, and newer drugs such as pegloticase and rasparicase. Actually, acute gout, it occurs due to abrupt onset of severe inflammation in the small joint. It causes severe pain and requires immediate treatment. Chronic gout is due to persistence of pain and stiffness between the attacks of gout. Other features include tophi, that is chalk-like stones, kidney stones, urate crystals in the kidneys, joint destruction, and permanent deformities. Let us see the drugs used for acute gout, that is NSAIDs. The NSAIDs used in gout they have the potential for anti-inflammatory action. They do not have uricosuric action. They are usually preferred over colchicine due to comparatively less toxicity. Some of the NSAIDs used in acute gout include Indomethacin, Naproxen, Diclofenac, and Piroxicam. Prolonged use of NSAIDs are not recommended because of the risk of renal, vascular, and GI toxicities. Let us see the colchicine, which is used for acute gout treatment. It is an alkaloid that lacks analgesic or uricosuric action, but possesses selective anti-inflammatory effect in acute gout and produces dramatic relief. You can see this scheme. Colchicine binds to tubulin, leading to depolymerization. It prevents migration of granulocytes into the inflamed area. It decreases the release of pro-inflammatory mediators, and it has selective anti-inflammatory effect in the gout. It is used in acute gout to produce rapid response, but generally not preferred due to its toxicity. It is used in prophylaxis of acute gout during initiation therapy with allopurinol or uricosuric agents. Let us see the adverse effects of colchicine. The most common are GI toxicity, which manifests as nausea, vomiting, diarrhea, and abdominal disturbances. These are dose-limiting toxicities and should be discontinued once these adverse effects appear. Chronic therapy can lead to severe bone marrow depression, which manifests as agranulocytosis and aplastic anemia, myopathy, and alopecia. Overdose can lead to multisystem organ dysfunction such as CNS depression, renal damage, and GIT bleeding. Death can occur due to cardiovascular collapse and respiratory depression. Let us see about the corticosteroids, which are also used in treatment of acute gout. Corticosteroids are used in situations that are unresponsive to NSAIDs and colchicine. They can also be considered in situations where the patients are unable to receive NSAIDs due to toxicity. Systemic steroids such as prednisolone and methylprednisolone can be used. Intra-articular injection of steroids such as triamcinolone can be considered for monoarticular or single joint involvement. Let us see about Probenecid, which is used in treatment of chronic gout. Probenecid actually mobilizes the uric acid from the tophaceous deposits in the renal tubule. The uric acid is mainly reabsorbed by the tubules with the presence of a transporter called URAT1, which is an organic anion transporter. This transporter is blocked by the probenecid, thus decreases the reabsorption of uric acid and increases the excretion of uric acid. Probenecid increases the renal excretion of uric acid, so liberal fluid intake is advisable to reduce the risk of uric acid stones in the urinary tract. It is ineffective in the presence of renal insufficiency and should not be given to patients with creatinine clearance less than 50 ml per minute. Probenecid should not be given in acute gout because it can precipitate acute gout. The adverse effects, it is minor, it includes dyspepsia and rashes. The drug interactions are numerous. With penicillin, cephalosporins and sulfonamides, the organic anion transporter is blocked. Thus, the blood levels of antibiotics are increased. Probenecid can cause the same thing with Indomethacin and Methotrexate. Reduces the tubular secretion of these Indomethacin and Methotrexate. With nitrofurantoin, it can reduce the antiseptic effect, urinary antiseptic effect of nitrofurantoin. With aspirin, the aspirin can reduce the efficacy of probenecid. Sulfenpyrazone is a drug which is similar to probenecid. Let us see the allopurinol, which is used in treatment of chronic gout. It is a competitive inhibitor of xanthine oxidase and it reduces the uric acid synthesis. Its major metabolite is alloxanthine, which is non-competitive inhibitor of xanthine oxidase. Hypoxanthine and xanthine are soluble and can be excreted in urine. It can also cause feedback inhibition of de novo synthesis of purines. The therapeutic uses, these drugs are not preferred during acute gout due to the risk of precipitation of an acute attack. The chances of precipitation of acute attack are higher during initial 1 to 2 months of therapy. It is used in secondary hyperuricemia resulting from drugs such as thiazides, anti-cancer medications and radiation therapy. Allopurinol with 6 mercury of urine. When it is given, the dose of 6 mercury of urine should be reduced to 1/3 because it can potentiate the effect of 6 mercury of urine in patients receiving it because it is metabolized by xanthine oxidase. The adverse effects include hypersensitivity, Stevenson-Johnson syndrome, nausea and vomiting. It is contraindicated in pregnancy, lactation and in patients with renal or hepatic disease. Let us see about Febuxostat. There is a clue XO, so it is in the drug name. It is a xanthine oxidase inhibitor. It's a non-purine inhibitor of xanthine oxidase and reduces the formation of uric acid. It is used in chronic hyperuricemia in patients of gout. It can be used in patients who are intolerant to allopurinol. The adverse effects include hepatic dysfunction, headache and diarrhea. Let us see about the new drugs for the treatment of chronic gout. They are peglitocase and raspberrycase. Actually, the birds, they can solubilize the uric acid. They convert uric acid to allantoin. It is an inert and water-soluble substance and that is excreted in urine. That capacity is not there in the humans. But now, these enzymes are available for use in the humans. So, peglitocase and raspberrycase are recombinant uricase that converts uric acid to allantoin in humans. Allantoin is excreted in urine. Peglitocase is indicated for the treatment of chronic gout in adult patients refractory to conventional therapy. Flaring of gout can occur during initiation of anti-hyperuricemic therapy with these enzymes. Hence, prophylaxis for gout flare is recommended with NSAIDs or colchicine starting at least 1 week before initiation of therapy with peglitocase and lasting for at least 6 months. So it's a very short information of all the anti-gout drugs. I hope it will be useful for you. Thank you for listening. Happy learning. Kindly share this to more of your friends. Kindly subscribe to our Pharma Topics channel. Thank you for listening. Thank you.